All right. Thank you all for hanging in there. I hope there have been lots of great conversations. I know I've had the opportunity to meet so many of you and carry on conversations that we may have started over email or intended to begin through LinkedIn. But now I'm reverting to my original approach anyway, of just introducing you to someone that I've gotten to know over the last several months. Dr. Tina Shah, I'm sure we'll share more about her background, but she has a large pedigree of incredible work, Surgeon General, White House Fellow. I met her actually in March at the International Virtual Reality and Healthcare Summit. And Walter actually said that was the best talk I've ever heard, or at least I feel like that's exactly what you said. And anytime someone like Walter, who hears these things and communicates himself all over the world, says those types of things, we ensure that we follow up. Tina has also graciously joined us as a member of our executive roundtable that we mentioned earlier, as has Walter and Skip, that you'll hear from tomorrow. But with that, Dr. Tina Shah.
No pressure, right? Well, I want to share a little bit more. It feels like I'm coming home. And while we're not sitting in VA headquarters, which is just down the street, I feel like I was plucked from my world as a physician, finishing up my training and put into VA. And then my eyes opened up as to what the possibilities were in healthcare. And so Anne alluded to this, but I was part of a program called the White House Fellowship, where I had a dual appointment under the Obama and Trump administration in the White House and with VA. And so I served under Secretary McDonald and Secretary Shulkin. And actually, our current Undersecretary for Health, Dr. El Nahal, is a person that was just 1 year ahead of me in the White House Fellowship. So it's been really fantastic to come back here again. And while that time I was VA's first director of clinician well-being, and you'll see I'm a broken record. I'm all about the veteran experience, but by way of the clinician experience, because that's a necessary piece. I just need to show, I hope I can kind of get across how great VA is doing on this front and how much more VA could lead the entire country because of the infrastructure it has. So let me start by saying, who knows what the fourth mission is? Okay, few people. So VA does a lot of things. VA provides healthcare for veterans and a lot of other things for veterans after they come out of their service time, but it also has this fourth mission. And that fourth mission is during natural disasters, during emergencies, during wildfires, VA actually deploys across the country and supports the communities. So while we may think of FEMA and we may think of the National Guard, the VA has been the backbone for many, many different deployments as we deal with natural disasters. And what a week we've had in the last 7 days, right? With Maui and California and Washington State. And I think the list goes on and on with what's been happening with wildfires. This is bread and butter for VA. VA knows how to do this. But I'm not putting this picture up here because I want to talk about the fourth mission. When I think about what it's like to practice present day as a pulmonary and critical care doctor, and that's what I am, this is what going to work feels like. I didn't expect this as a med student. I definitely didn't expect this when I trained in the Wilmington, Delaware VA as a resident. And I didn't expect this coming out of the pandemic, but this is what it's like for me every time I'm on service in the ICU in an urban hospital in New Jersey. Let me give you an example of what it feels like right now. So 2 weeks ago, I was on service and there was a patient we were taking care of who had a dangerously low sugar. I think many of us have probably dealt with that. You start feeling a little woozy, you might start sweating. The problem is if you don't raise that sugar level, you will go into a cardiac arrest. So naturally, what do? You give the person sugar, or in our case, sugar water, also known as D50 for the clinicians out there. But here's the thing, I wasn't in middle of nowhere America. I was in a very, very well-to-do, well-resourced hospital, and we couldn't find the sugar water. We literally ran out. I mean, this is a life-saving med. The ICU nurses ran around the unit, then they left the ICU, they ran across the floor to try and find this. And we mixed sugar and water and then gave it to the patient in the hopes that we were there, we'd get there in time. But that's what it's like training. That's what it's like taking care of patients. There are severe supply shortages. Number two, why is the ER closing down? Why can't we take more patients? You know what? We have a major labor shortage right now. There literally aren't enough nurses to take in more people that desperately need us. So I have been now part of, I don't know how many different times we've closed down the ER unless someone comes in via ambulance because we literally don't have enough nurses upstairs to take care of patients. Do you know how distressing that is? And then the third one, well, we're coming out of the pandemic, finances are tight. Doc, you better do more, but no, I'm not going to give you more. And it's not just my story as a doctor. This is the story of the case manager, of the occupational therapist, of the pharmacist, of the physical therapist. Any person that works in the health system right now is feeling this pressure of do more, do more, do more, but we're not going to give you more. In fact, you actually have less resources than before the pandemic, even if we go back 1 year. So when I think about healthcare, I don't think about healthcare in the US as we're on the brink of disaster. I think of it like this. We're in the disaster and healthcare is breaking down. Let me ask you a question. Would you be okay having a coin flip when it comes to your health? What if I told you that 50% of the time that you see your doctor, you might not get good care? Raise your hand if you're okay with that. Yeah, you better not be, right? But that's the scenario because right now, 50% of doctors in the US are burnt out. That number is nearly identical for nursing. In some places, like nurses that work in the hospital on the inpatient side, it's approaching 62%. I will go through a little bit more about what burnout is, but the summation is when we're burnt out, despite our best efforts, despite the best training, we can't do the best by you when you come in to see us. And what do I mean by burnout? This is what I mean by burnout. Burnout is an occupational diagnosis. It has a very specific definition, which is about how the clinician feels when they think about work. And they only need to have one of the three different things that characterize burnout. Either emotional exhaustion, depersonalization. This is starting to see people as objects, as another task, another piece of work to do instead of human beings. And a low sense of personal accomplishment. For example, I finish a day and I think, did I actually help anyone? So, this doesn't happen in a vacuum. This is literally when, and if we look at my beautiful rendering here, but this is when job demands outweigh the job resources we're given. We don't actually start out burned out, whether, we're nurses, doctors, whatever type of clinician we are. In fact, we're some of the most resilient people on earth when we compare ourselves to our peers in other industries. But burnout is an occupational condition. It is caused by a toxic workplace. It turns out pretty much every healthcare setting puts us at risk because it's ubiquitous. And this isn't depression. This isn't, I'm constantly feeling like I'm in a low mood. I have this for, these feelings for at least 2 weeks. And because it's a medical diagnosis, I need a medical treatment, which is then therapy plus minus medicine. Burnout is an occupational diagnosis due to the factors of the workplace and therefore requires a workplace solution. Don't worry, I'm getting to the connection to VR. Just hang in with me for a second. So here's the thing. We've been talking about all these amazing things that we can do to help veterans. But I tell you this, if we don't focus on the clinicians, we won't be able to hit any aim because clinician well-being affects every single goal we have in US healthcare. This is the Institute for Healthcare Improvement's quintuple aim. It's something you may have seen around, but it's essentially the guiding principles about what is the goal state when we talk about delivering good healthcare in the US. And I've put around just a few factoids, all research-based. You can see my references here, but I have to prove this point to you. So allow me to prove this point. Okay, we have a study that shows when nurses and doctors are burnt out, and specifically they have the emotional exhaustion, that this leads to increased mortality in the ICU. We also know that there's an increase in medical errors when this was studied in surgeons. They're not the only ones, but I'm just trying to give you a range of the widespread research we have on this subject. Even more concerning as we continue to march along with D, E, I, and belonging, We actually have a study that was published last year that looked at resident physicians or doctors in training and found that when they're really burnt out, they tend to express more biases towards Black patients, as in we give differential care. And when we get unburnt out, as in when we address the drivers that cause us to burn out, those explicit and implicit biases go away. We know that when you're burnt out, we actually have increased turnover, we have decreased productivity that impacts cost. And I think many of us can probably attest to this. When someone's distracted, when they're burnt out and they're our nurse or our doctor, we don't have the best experience, right? We don't feel listened to. So if we don't address clinician well-being, we just won't be able to make any gains. And that's what we need to think about as we're in the early phases of extended reality. I need to bring you some numbers, and this is from the private sector outside VA, but it literally costs us $1 million every time we lose a doctor to burnout. Pre-pandemic, that amounted to $4.6 billion annually looking at the US healthcare system. And that's a preventable cost, right? Because we could redesign the workplace and let our elite athletes, known as doctors and nurses and pharmacists, just be able to do their jobs, but we haven't designed the workplace in the right way. It's very expensive. So Anne alluded to one of the jobs I had, and I got to tell you this story. I was literally making a road trip on vacation, and I got this phone call, and it was from a blocked number. And if you've ever worked for the federal government, you know it's not a scammer, you know it's someone important. So I pulled over on the side of the road and I picked up the phone, and it was our current US Surgeon General, Dr. Vivek Murthy. And he's like, "Hey, Tina, what's up?" And in my head, I'm like, "You're the Surgeon General, what's up with you?" You know? And this was 2020, I think it was the end of 2020. And what he told me was COVID. My priorities 1, 2, 3, 4, 5 are COVID. Right after that, though, it's our healthcare workforce, because if we don't have enough of them left, and if they aren't fully functional, they're just getting beaten up every day with what's happening with the pandemic. How are we going to take care of everyone in the US? And the Surgeon General is our nation's doctor. That's literally their job. Their job is to look at the health and the well-being of everyone that lives in our borders. So when he said that, those were the magic words. He wanted to make health worker well-being a national priority. And I was privileged enough to become a senior advisor and come up with that strategy. And so when we look at, and this is actually a page from the Surgeon General's advisory on health worker burnout, it is the nation's blueprint on how we're going to address a great resignation in healthcare. You can see that it's not one little thing that causes burnout. I mean, we're talking about stuff from the societal level and thinking about misinformation, all the way down to our workplace and thinking about violence and discrimination and not having enough time with our patients. And the truth is, as a doctor, the studies show that a doctor spends on average 2 hours on paperwork for every 1 hour with a patient. On the nursing side, inpatient nurses spend 42% of their time nursing the computer instead of nursing the person in the bed. How is that okay? So put this in context, by the way. We talk about having a shortage of nurses and doctors, but look at what we're telling them to do. I hope this is starting to trigger some things, because everyone in this room has just been soaked in the promise of all the technology we've heard of. And I want you to start thinking about, how does it apply here? So I have to give you 3 things, okay? But before I get there, let me start with one thing. Raise your hand if you have right now a smartwatch or a phone that vibrates or dings or something. Perfect. Okay. Keep them up. Keep them up. Now, keep your hand up if in this time, and I think it's been about, if I can count properly, 13 minutes. I won't judge. Keep your hand up if you've been interrupted or it's dinged or something. Okay. So we have some people. Okay. Every time that happens, have you noticed that you immediately look at whatever it is, and then it takes you a moment to kind of get back to where you were, or you altogether don't even get back to where you were? So listen, I am going to throw some shade. I really think you should listen to me, but I understand. I understand. I'm competing against your phone. But that is actually one of the biggest issues that drives burnout for us. Except for us clinicians, burnout causes biological changes in the brain. And what I'm showing you here is 4 parts of the brain that then make us ineffective. So I'm giving you the scientific link between how our workplace is structured, what happens to our brain, and how it manifests. And what it manifests in is decreased focus in your doc, decreased quality of medical decision-making, short-term memory loss, and long-term memory loss. Now, does this sound good to you? So it's not a small problem, it's a major problem. And when we think about tech, we have to think about all of this technology and how we have to implement it now so that we improve cognitive capacity, because we don't have time to waste. I don't want us to make the same mistake that we made when we implemented the electronic medical record and all these various technologies, because we don't even have the same workforce anymore. We have even less. In fact, in 2021, we lost 10% of our physician workforce. That's 100K doctors. No one knows that, but that's what happened. So let me take you through the science of well-being. And this is really human factors and ergonomics. And this is the foundation for how, when we design and when we implement AR and VR, how we have to incorporate this piece, because if the clinician's not well, then we won't have the veteran be well either. And when we think about the brain, I like to think about it as a battery. There's 3 types of load. There's intrinsic load. That is the effort it takes for me to put together the pieces and figure out what to do next with your diagnosis of lymphoma. So do we go with treatment A or do we go with treatment B? The second piece is germane load. Now, germane load is actually about the mental model of how I bring together the data and then come up with the diagnosis. So as a senior physician, I see somebody who looks sweaty, who's clutching their chest. I know that's a heart attack very quickly. When I was a med student, it took me a little bit longer to put the pieces together. So this is about assembling information and creating a mental model of what is in front of you. And then the last one, which should never be part of the brain battery, but it is there and it is way too big, is extraneous load. This is your phone dinging. This is your watch vibrating. It is task switching. It is having to go and grab, for a person like me, grab a fax, because I still grab faxes, then go to one electronic medical record and sift through 10 different screens to get 2 pieces of information, then ask the nurse, did I miss anything? Because she actually talked to the patient's dad, and then putting all that together. So right now, because of how we operate, this is a clinician's battery, brain battery. And when someone comes in with chest pain, they have no space left to think. They need space in their brain battery. So what's a goal? Well, let's take extraneous load and let's reduce it down. We shouldn't have to take a really, really, highly trained clinician and tell them to curate data from all these different spaces. And when it comes to implementing technology, it's the same thing. It can't be a point solution anymore. It's got to be integrated in our workflow, not the other way around. I actually think there's quite a bit that VR and AR can do on the germane model. And I was talking to a really amazing company on the other side who is using simulation with AR to help people understand how physiology works for blood clots and for strokes. So the quicker we get trained so that we can learn how to put the information together, the smaller the germane load is going to be. And so when that patient comes in with chest pain, we have space in our brains to do that critical thinking and not make a medical mistake. I have to mention this too. It is critical that we think about resiliency, but 85% of what drives clinicians to burnout is due to the workplace. So working on resiliency is helpful, but it's insufficient. We have to have both effect on the system and targeted interventions on the individual. And actually, we know a lot about what it takes to solve for burnout. This is actually a diagram. It's 5 things that are evidence-based that actually was developed in the middle of the pandemic, and it's endorsed by the National Academy of Medicine. I was privileged to co-chair the group that came together with this. But think about the applications for extended reality now. Can you get rid of stupid stuff for us? Can you pull together all the information with AR so that we don't have to spend 20 minutes getting one little picture of how this patient was in the last month? Can you think about how EAP, which is employee assistance programs, or the crisis number you're supposed to call when something crazy has happened to you at work and you're mentally distressed, Can you help us manage that before it even happens? I think so. So we actually do know what works. Now it's about getting the tech to apply it so we can do it at scale. And I'm really proud to say that VA is really at the forefront of thinking about how we help clinicians thrive. If there's anyone in this room that's involved with Reboot, which is a task force focused on clinician well-being, there is so much that they are doing alongside Whole Health, which is an initiative initially for thinking about what matters to you for veterans, but is now going to be offered to every employee in VA. I mean, there's just so much opportunity here with a backbone of, this infrastructure from the innovation office on this technology, and actually having the operational infrastructure of thinking about what's it going to take to help a clinician thrive. So this is my challenge for everyone in the room, on the vendor side, on the leader side, on the veteran side, and on the clinician side. What are we going to do with this new technology so that we can get to this state of thriving for our veterans, and by way of that, also our clinicians? So you know what? It's Christmas for Tina. Tina's going to tell you her wish list. This is it. Number one, did you say that your solution helps? Well, I need you to prove it now. You can't just prove it with the outcomes of, hey, we improved this depression score. I want you to tell me, is this product actually reducing the cognitive load for clinicians? Or is it increasing it? Because if it's increasing it, it won't be adapted. And I don't know if anyone was here for the veteran panel we just had, but seated over here was a gentleman named Kevin, who is a nurse and also an informaticist. And what he was saying is that one of the biggest pushbacks he gets is that clinicians are too busy to put the VR headset on the veteran. And I have to tell you, why are we asking the clinician to do this? We don't have time. How can we redesign how we bring this technology in given our real environment? You have to think about the true clinician reality. Number two, this is probably the smallest amount of data I'm looking at a second-to-second basis, but this is a telemetry monitor in the ICU, and it's moving in real time, second by second, and my brain is synthesizing all of that. And now you're telling me I have to use AR too. So can you help me reduce split attention? Because that's one of the biggest things that drives cognitive load, which causes the brain matter changes, which causes me not to be the best doctor I can be. Can you address poor standardization and just make it easy? If we're going to be using AR in one setting in the hospital, we should easily be able to use it in the same way in the other setting of the hospital. I shouldn't have to learn when to use it and when not to use it. It needs to be simple. Can you help consolidate the information and really help me drop that extraneous load for the nurses and the doctors that are helping to use this technology? And especially as we think about VA as a high reliability organization and being at the forefront of quality and safety, redundancy has a very, very ugly consequence. And that is that it causes cognitive load, which again causes brain matter changes and causes burnout in your nurses and doctors. So being redundant isn't always a good thing. Can you just give us the information in the right way just once? Also, and I think we're really moving and shaking along these lines, but how do we incorporate VR and AR to better train us for clinician reality? This is a picture of me. I'm actually running a simulation cardiac arrest. I was in Parker, Arizona in the Indian Health Service, so in rural Arizona. And this is what it was. We had a half body sim man. I was just calling out what was happening with the patient, so I was making up this scenario, and people were gowned up as they had all their PPE on and trying to go through this. But imagine if it felt more real than that, because that's a piece of plastic. That's not exactly a human body. So can you train us so that we're not just seeing one and then doing one and teaching one, which is the adage we use in physicians in medicine? We need to see 50, right? We need to see 50 virtual simulations of something before we even lay hands on a veteran. That's how the training standard should be. Help us do that. And then, can you help us transfer the clinician experience? This one really hits home because last month I almost broke a computer. It was like a repeat of The Office, that movie where you take the bat and you're just hitting things. And it's because it took more than 15 minutes to load up this computer on wheels, but I had crashing patients in the ICU. And then once I loaded it up, I moved and then we had a dead spot with Wi-Fi and I couldn't see the data, but the patient was crashing. That is my reality, but I don't think my administrator knows that. Can you help us by using this technology to translate the experience? And can you help us understand the veteran experience by bringing it to us and really allowing us to walk in their shoes? I think this one is big and underutilized. And I can't stop without giving you a sports reference. In this case, it's basketball on my mind. The time for man-to-man defense is over, folks. This is all about zone. This is how we practice medicine still. We have one nurse, that nurse has 3 patients, or post-pandemic has 7 patients, but that's just it's not feasible anymore. How do we use this technology so that it's a team model where as soon as one nurse is a little bit more available, he or she can help with the other patients, and it's a team effort, which allows us to cover more ground and prevent patients from getting sicker. How do we really function as a team? I think there's a very, very big role now for extended reality to help us get this, both to train and work as a multidisciplinary team. And actually, I'm going to say that's including the veteran in as the teammate, because we don't do that well enough yet. And then also practicing that. And I wish I could get that as a doctor today, even though I'm done with my training. Although I've talked about resiliency being something that is necessary but insufficient, the truth is the only constant in healthcare right now is turbulence and change. And when we're in that situation, and it really feels like that every single moment we step into the clinic or we step into the hospital, we need something right now. And I think the possibility of this technology to have a one-to-one target to help me lower my stress level so that I can see and I can think and help that patient in front of me right away, to give me that biofeedback so I can learn how to control myself and be more effective when the next thing happens. That's critical. And we actually don't have that. What we have right now is a bunch of alarms going off. We have a person coming up and saying, "Hey doc, we need you." We have, a patient that's yelling. We're so distracted, and it's really hard to calm our bodies down so that we can do our best thinking. We don't often get to celebrate, but I bring this up, and I'm there in the pink mask. This was Critical Care Month, and we were celebrating all of the patient wins last year. So this is me at Hackensack Medical Center in New Jersey. And we just don't get enough days like this, but I feel like medicine's a team sport. And so I'm on the team, Walter, you're on the team, everyone's on the team. And what does it look like when we're working in a team together? Can you help us get more wins like this? Because when this happens, the real thing happens, which is that the veteran gets to get the best possible care and she can just live her life how she wants and not have to worry about her health. So that's my challenge to us. Can we think in the next few days, and I know we're about to hear some more information about what we're actually doing to help with staff as we deploy this technology with well-being, but how do we have more good days like this? Because when this happens, then we'll really transform U.S. healthcare. Thanks, everyone.
Thank you so much, Dr. Shah. I really appreciate it. I have to agree with Walter. That was an incredible presentation. Thank you. I know so many are going to want to grab you and talk to you later. We actually, we have a panel coming up next, and I don't know, are you guys bringing chairs and tables again? I'm looking for visuals and guidance. Yes. Okay. So while they're setting those up, Tina, if you'd be willing, any questions in the audience based on a presentation you've just seen? I also know we didn't have the opportunity to ask questions directly to Caitlin. So since she's standing right there, I'm going to ask her to come up as well. This is why they love me, because I just throw them in the deep end. But any questions for Tina about burnout or incredible experience that she's had, or Caitlin from an operations perspective with Immersive? Walter's going to start calling on people if no questions. He does have that look in his eye. That's right.
see that we could use VR or AR for to address on the burnout front, so that, you know, our nurses and doctors can actually focus on veterans. I don't know if you raise your hand or not, but go ahead.
Over Nurses Month, I did 12 different sessions for our nurses, days, nights, was able to reach 80 nurses, RNs, LPNs, and 78 reported a change in their mood in that pre to post. We know this technology works, and I co-lead with my partner in caring here, Barry Peterson, one of the community of participation calls for this, the Immersive Network. And we've been thinking about this and trying to crack that code on that cultural change of I don't have enough time. And it's been really profound. So maybe this isn't a question, but it is really profound to be able to say, in the experience of having a nurse come in that's lost a patient veteran earlier in the day and have them sit down and they're sad, they feel sad, and have them be able to have an experience where they can move out of that physical space. You know, we don't leave the hospital during the work shift often, and we are just going and going and going. And I recall it quite vividly that she was like, I can be in nature during my work shift, right? And we know this doesn't take a half an hour, it takes 5 minutes. And you can show pre-post. So what would you say? What is that magic key to unlock that door? Do you have any insight? Because we're thinking about it, we're working on it, we're collecting that data. We have the headsets that are available. What we've seen, I think, is that it needs to be a sponsored experience, right? Sometimes it's just too much to add that extra that you can go do it. But here, we're offering it. Let us come in and care for you. So do you have any insight?
Yeah, first I want to commend you for trying to mediate that risk, because I'm just thinking about ICU nurses. Obviously, I'm biased. I think ICU is the best place to work. But yeah, when someone dies, you still have 2 more people to take care of. And they might be crashing and almost dying too, so you almost don't have time. But if you can help them step away, but by bringing it to them, because if it's in a different room, we just don't even have the time to walk there. That's helpful. If you look at it on a grand scale, if it's really something sponsored by leadership, then we would build a little extra staff so that we can have that nurse take the 5-minute break. So we have a bit of a cultural issue where we sometimes don't have enough staff to be able to give that break. So this is about, you know, negotiating with the clinical side of the house to say, we need to allow for this, because it turns out nurses are human too, and they can't function like robots. So I think when you show the pre-post, that hopefully will pull on the emotional heartstrings of the senior leaders. I also think helping to come up with a module that shows senior leaders how stressful it is in the operating room when something goes wrong, delivering bad news that a pediatric patient has cancer. Those things are the things we do every day, but people don't really realize what happens to us when we do that.
Hi. So my company is, I'm Yael Swerdlow, and my company is Maestro Games. We're a little bit different. We are neuroaesthetic technology. So we are a intersection of behavioral health, the arts, and neuroscience. Our first case study peer review was at Children's Hospital in Orange County with the nurses, and showed that we had a marked improvement on their secondary PTSD and also on their burnout. So one of the things that's really been interesting about this space, though, is that they put us in pop-up stations. So when something happened, they would rotate from oncology to nephrology to surgery to whatever. Then a nurse would come out, and instead of maybe going into the bathroom and cry, which is what normally would happen, she would go to one of the pop-up stations and do the demo that they used for the case study, and then go back out on the floor and have that level of resilience to be able to come back out.
I think that's a great example. And my hope is that it continues to evolve, where it becomes easier and easier for that nurse to even walk over because we still have that challenge as clinicians to have the time. But where I work, there's no, I can't, the only time I can see sunlight is through a patient's window. I never have quiet. I'm constantly distracted. And then I still have to make sure I can drive home and not get in a car accident. It's pretty high stakes.
Thank you so much. Appreciate the questions and conversations. Thank you, Tina, for your time, your expertise. I know we'll have a lot more conversations with you over the next day and a half.